Welcome to Defending the Opioid Problem, Where We Are and How We Got Here, presented by Julie Stevens. This is the first presentation in the virtual Community Opioid Symposium. This free educational event is brought to you by the Louisiana Department of Health Office of Behavioral Health, Acadiana Area Human Services District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for prevention and treatment of opioid use, misuse, and abuse. Today's presentation is the first in a series. For more information on future presentations, please visit womensfoundation.com/COS. This session is accredited for 1.5 hours for the following: social workers general credit, addiction specialist, AMA PRA Category 1 credit, and it was submitted for approval for 1.5 CEUs for licensed professional counselors. Full participation is required to receive credit and will be monitored throughout the session. After the event, you will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificate. Julie Stevens has no financial disclosures. None of the members of the symposium's planning committee have any financial disclosures. Julie Stevens has been in the addiction field for 35 years. She is an advanced certified prevention specialist and was a licensed chemical dependency counselor for 20 years. She has served as Director of Prevention for the Texas Commission on Alcohol and Drug Abuse and training specialist for the University of Oklahoma's Southwest Prevention Center, and most recently as Executive Director of Life Steps Council on Alcohol and Drugs. She is currently chair of the Prevention Specialist Committee of the International Certification and Reciprocity Consortium. Ms. Stevens serves on the Texas Certification Board of Addiction Professionals and is chair of the Prevention Subcommittee. She has a bachelor's degree in psychology from Baylor University, 15 postgraduate hours in clinical psychology, and a master's of prevention science from the University of Oklahoma. In addition, Ms. Stevens is an adjunct professor for the University of Oklahoma College of Liberal Studies. She teaches core courses for Masters of Prevention Science, including Foundations of Prevention and Prevention Across the Lifespan. And Ms. Stevens, you're very well accomplished, and I apologize if I got any of that incorrect. But without further ado, I give you our presenter, Ms. Julie Stevens.
Excuse me, I just decided to turn my phone off. So if I get any messages or phone calls, they won't disturb us. Well, thank you, and thank you for having me today. And I'm impressed by the audience, by the number of people and the variety and diversity of people attending. All, of course, interested in the opioid problem in our country. My specialty is prevention. Like she said, I'm a certified prevention specialist. Been doing that for a long time. I was a counselor for a little while, but I'm not good at that. And so I came over to the prevention side of things. But thank you for coming. We're going to talk about opioids today. And, I might be a little rough using this platform, but hopefully everything will work. So we're looking at defining the opioid problem. And I'm gonna show you a lot of data today, and it's the latest data I could find. Some of it is 2017, some 2018, a little 2019 data. So, but like I said, it's the latest that I could find from CDC and from NIDA and other places that have the data. And we're going to look at prescription opioids. What's very interesting to me is how we got here and what contributed to our crisis. And then also I've done some work on finding specific data for the state of Louisiana. So that's what we'll be looking at today. So the definition of opioids, you know, the DEA and other federal agencies still refer to opioids as narcotics. I don't know how the term opioids got replaced, but when we talk about narcotics, we're also talking about opioids, and it comes from a Greek word which refers to how it dulls our senses and relieves pain. So, but it's aligned with opium and opium derivatives and semi-synthetic and synthetic substitutes for opium. So we're not talking about cocaine and other marijuana, those other types of drugs. When we talk about opioids, we're talking about those things that are derived specifically from opium. So illicit the drug heroin, which has no medical use at all and is totally illegal. But also we're looking at some pharmaceutical drugs, Oxycontin, Vicodin, codeine, fentanyl is one that you may be pretty familiar with as well. Opium comes from a poppy, and it's grown, you know, in the Middle East and also I think in South America. And so that poppy is the source for all the natural opioids, which include opium itself, morphine, and codeine. So those three things are derived specifically and directly from the poppy. Then there are semi-synthetic opioids, and that means they have some of the morphine in them, but they also have other things like heroin, oxycodone, hydrocodone are semi-synthetic. And then there are those opioids that are purely synthetic and made in the lab, and those methadone and fentanyl are some of those products. And so, you know, you may hear the term synthetic or semi-synthetics, and so this is what we would be talking about in that case. I don't know that we really have a lot of natural occurring opioids, opium, morphine, and codeine, because what we're going to be talking about that are abused are more semi-synthetic and synthetic opioids. What do they look like? You know, they come in tablets and patches and powders and chunks, and this says varying from white to shades of brown. The white heroin comes from the Middle East. It's processed a little more thoroughly, and then the brown and the black tar heroin come from Mexico, South America, and there's a different process for creating those forms. Liquid forms, suppositories, lollipops. It can be swallowed, smoked, sniffed, injected. And so this is what, you know, the various forms that it comes in, lots of different ways that it comes. And how does it affect your body? It affects several different parts of your body. In the brain, it can cause daytime sleepiness, which could also require additional stimulation. So it may be that somebody takes, so here's my brain, somebody takes, you know, a stimulant to get over that sleepiness. And it might create a nodding off effect, slipping in and out of consciousness. Long-term use of painkillers is associated with heightened risk of major depression. So, and then, you know, sometimes patients use painkillers, and if they use them more than 6 months, then it can definitely cause major depressive episodes. It also affects the respiratory system over here on the lungs. And this is the most dangerous thing because overdosing on painkillers, opioids, or heroin can lead to respiratory depression, slow breathing, and respiratory arrest if it's in larger doses. And what happens is it deprives the brain and body tissues of oxygen. And so this is the major problem. It can prove fatal or result in some sort of organ system injury. It affects your digestive system. And some of us are familiar with this because it can lead to constipation and then slow the digestive transit process. So slowed intergastrial motility and chronic constipation associated with opiate use can also place users at risk for more serious conditions, such as small bowel obstruction and perforation. Nausea is also occurs frequently with the use of opioids as well. Sometimes uncontrollable vomiting can occur. And then in the nervous system, here we go. The nervous system, actually use of opioids can develop hyperanalgesia, which is a sense, means that you're more susceptible to and sensitive to pain. So it's kind of, you know, the opposite of what it's supposed to do in terms of relieving pain. In the immune system, opioids can suppress the immune system because the opioid receptors in your brain, because we have natural opioid receptors and opioids in our body, are there because they regulate immunity. So, and then in the liver, they can, very often you'll receive a prescription for an opioid that's combined with acetaminophen. And so excessive use of these types of drugs can damage the liver and cause acetaminophen toxicity. And then we also, of course, are very aware that if you add alcohol to the mix, then that also damages the liver, and many opiate abusers do this. It's very risky to do that. And so you can have serious liver injury if you combine opiates with alcohol. Also, you know, some opiate users inject the opiates, and they use maybe illicit street drugs to do that. For example, heroin is one thing, and we know that injecting contaminated heroin, because very often street heroin is contaminated, can infect the blood and the lining of the heart. So that's a problem. And also, of course, injecting heroin and sharing needles can lead to spread HIV and AIDS. And so these are some of the issues and the problems with using opiates and how it affects the body. It's a major health problem in the United States and contributes to overdose deaths, including the use of illicit opioids and prescription opioids as well. And in 2019, which is the latest data, there were over 47,600 deaths in the United States in 2019 attributed to opioids. Now, when we talk about drug overdose deaths, that's a big category, and we try to narrow that down to those overdoses that are involve opioids specifically. So yeah, it continues to be a problem. I want to show you a video about the epidemic and what's happening now.
Tonight, we begin a week-long series looking at the opioid epidemic, a serious issue around the country. The CDC says each day, 91 people die from overdoses. 91. Senior correspondent Rick Leventhal tells us where we are right now and the surprising way this country got here.
On any given day, the Warwick, Rhode Island Fire Department's Rescue 1 rolls on a dozen calls. Traffic accidents are routine, and so are overdoses on opioids like heroin, fentanyl, and oxycodone.
And we spray this up into the nostril.
Rescue Lieutenant Henrik Dunleavy shows one of the methods for administering Narcan, a life-saving drug for opioid OD. He's seen a dramatic uptick in addict rescue calls in his 17 years on the job, and sometimes saves the same people over and over again.
They're this close to dying, and then you get them back with Narcan, and they're awake and they're talking, and they're like, oh no, I didn't do anything, and then finally they admit, oh, I was doing heroin. Okay, well, don't do that again. And then like next week you come back, and there they are again. And and you hit them again when Narcan came back. I'm like, what are you doing?
The worst drug-induced epidemic in U.S. history.
Bertha Madras is a neuroscientist on President Trump's opioid task force. She says the crisis traces its origins to a pair of studies in the 1980s, including this one in the New England Journal of Medicine, which declared addiction was rare for patients treated with narcotics. Pharmaceutical companies launched aggressive campaigns promoting powerful meds like Vicodin and OxyContin. There was movement to name pain as the fifth vital sign, and physicians began writing hundreds of millions of prescriptions based on what Madras calls poor science.
Nobody had done long-term studies on treating chronic pain with opioids. There was nothing in the literature.
You can't overstate the pressures that were put on young physicians in the late 80s and early 90s to treat pain, not just adequately, but aggressively treat pain.
Dr. Michael Dacey is the president and COO of Rhode Island's Kent Hospital. 3 ODs arrived by ambulance in the hour or so we were there, 2 more the next day. Dr. Dacey says the medical community was misled, but it shares responsibility for this deadly scourge.
You had a combination of people fervently trying to do the right thing. At the same time as these more potent, newer forms of narcotics like OxyContin came along that were marketed initially as being not as addictive. Turns out they were at least as addictive. So you had this perfect storm coming together, and as physicians, we own a piece of this.
In upstate New York, the opioid epidemic forced Syracuse Behavioral Health Care to dramatically expand its facility.
We serve a couple of hundred patients. Now we're serving over 900. And that isn't enough. We're literally bursting at the seams.
The opiate treatment program distributes methadone and other drugs through dosing windows with nurses and counselors on duty around the clock. Because CEO Jeremy Klemanski says if addicts don't get immediate treatment, they will die.
We don't debate whether or not someone with chest pain would likely die if they didn't get into an emergency room. We don't debate whether a diabetic left untreated would really die of their diabetes and when. But for some reason in this sector of healthcare, sometimes there are people who want to debate those things. And the reality is the debate is over.
The number of people who die in the U.S. from drug overdoses every year is staggering. 52,000 in 2015. That's more than car crashes and gun homicides combined. In fact, opioids alone kill 91 Americans every single day.
The pain that pill caused me is a trillion times worse than any pain I would have endured, I'm sure. Go on.
Nathan Wendelowski got hooked on Oxy after surgery and eventually moved on to heroin, in and out of rehab for 10 years.
Why didn't it work? Why did the first time, the second time?
I didn't think I could do it. I just kind of was like, I loved it. It was my everything. I loved it more than my family, more than my job, more than my friends, more than my girlfriend at the time.
He's been sober 4 months and says the substance abuse program at Butler Hospital saved his life.
How do you know that you're not going to go back again?
I take it one day at a time. Yeah. And I see people dying all around me, people very close.
Yeah.
I have more people died that I know than I have fingers and toes.
Right before I left, the nurse or the receptionist said, "Ooh, honey, wait. I bet you're in pain. Let me have the doctor write you a prescription." And I'm like, a prescription for what?
Danielle Amaral says she got hooked when she was still a teenager after she went to the dentist to get her wisdom teeth pulled. Years of abuse later, she's taking another drug, Suboxone, which cuts her craving for Oxy and helps her live a sober life.
You think of addiction, you think of like a street drug and crack houses and scary places, and it's not. It's not. They're everyday people like that had no idea.
Nathan carries a clipping of a lost friend as a reminder of what could happen to him. There will likely be at least 50,000 similar obituaries this year. In Providence, Rhode Island, Rick Leventhal, Fox News.
So part of the first of this video talked about how this happened and how there was an article that said that the opioids were harmless and not addictive, and how pharmaceutical companies grasped onto that. You know, it was just a letter to the editor. We're going to talk more about that in a little while, because I think that's really interesting how this happened. Now, he quoted in there, he said in 2015, 91 people a day died of overdoses. This is the latest. This is from 2019, and the numbers that we have now state that 130 people die every day from opioid related overdoses. And then there's more data in here that you know is pretty interesting. I was looking for one that's talked about money, but you know, 2 million people misused opioid for the first time in 2018. 81,000 heroin for the first time. The 47,600 that died overdosing. And so this is some of the latest data on overdose and the epidemic from 2019. So the problem is, you know, there's two problems, of course. One is illicit use and getting heroin, for example, on the street. But another problem is prescription overdoses. And we're gonna look at that a little bit. 191 million opioid prescriptions were dispensed across the nation in 2017. Huge numbers, although they're going down, and I'll show you some data on that as well. But the most common drugs we're looking at was methadone, oxycodone, and hydrocodone. And so, you know, the prescription is the problem. So the problem, the opioids that are involved in this crisis include just our commonly prescribed opioids like codeine, morphine, oxycodone, hydrocodone, which are used to treat and manage pain from injuries and surgeries and cancer and, you know, chronic diseases. And they definitely have some health benefits, but then of course they also have the risk, including overdoses and addiction. So those commonly prescribed opioids are the ones I talked about a little bit earlier: the natural, the semi-synthetic, or the synthetic. Natural, morphine and codeine itself. Semi-synthetic is oxycodone, hydrocodone. Methadone is a synthetic opioid. Tramadol, synthetic, and fentanyl are synthetic. And then heroin is also semi-synthetic, which is of course illegal. And then there are other synthetic opioids like fentanyl, and fentanyl is extremely potent and can be deadly. Sometimes it's mixed with other drugs and people don't know what they're getting and they die from an overdose, you know, of fentanyl. And, you know, even though it's a legitimate drug that's used in surgery, you know, of course it's abused as well. And then heroin is illegal and has no pharmaceutical purpose at all. So it's a Schedule I drug, and it only poses health risk. And then it can also be mixed with other drugs like fentanyl and really be deadly. So these are the types of drugs that are involved in the crisis. So this is a death rate. This is interesting because if you look at the one on the left, 1999 death rates, and this is per 100,000 population, you'll see that most of the 1999 map is a light blue or turquoise. And then when we go over to the right side and we look at 2018 data, we see, you know, how much larger the problem is, and for states now. And you know, you can focus on Louisiana and see that it's one of the has the darker blue, and so it's one of the states that has one of the bigger problems. And so these are, let me just say, this is drug poisonings of all types of drugs, not just the opioids. So they didn't pull out that for this particular drug map. This is the types of opioids involved in overdose deaths from 1999 to 2018. So you can see that in 1999 it was very, very low. Now the light green on the top is any opioid, and then it looks like a dark green is a synthetic opioid, and then the purple looking one is methadone, and the orange is heroin. But this just gives you an idea of the extent that the drugs have been used, increased since 1999. So this is what, 20 years, over the last 20 years, information on overdose deaths at that time. So what do you see in this graph? You know, when you're looking at the graph, what do you think, what factors may have contributed, let's just say, to the rise in heroin use? That's the orange one, began rising in 2010. And it, you know, we have a chat box if anybody wants to use it, I don't know. But interesting ideas on, you know, what might have happened is that, first of all, there may be decreased availability of prescription drugs, and so people get heroin, and you know, sometimes it's cheaper than the prescription drugs. And also increased availability of heroin has probably contributed to the increase and being cheaper and more affordable. And you can see deaths from methadone have gone down a little bit. So that's the purple. And there is a spike, though, in the synthetic opioids. So that looks like the black one with the fentanyl. And so each of the categories show a significant increase in a trend from 1999 to 2016, and then a couple of them have leveled off a little bit since 2016. So just interesting data to see how the use of opioids has increased since 1999, and then perhaps we're making a little bit of headway since 2017, 2018 in decreasing those things. And so this is the number and rate, and we're talking prescriptions here, and you know, part of the problem is prescription opioids as well as illegal opioids, but much of it is prescription opioids. And you can see the height of the most prescribed per 100 people was in 2012. 81.3 prescriptions were written per 100 persons. And now in 2018, we've made some strides around reducing that number. And right now it's in 2018, 51.4. So the prescription rate has actually gone down. So what that means is, you know, we have 327 million people in the United States in 2018 with 168 million prescriptions filled at that point in 2018 as well. So lots of people getting prescriptions for opioids. And who actually is using the opioids, you ask? Well, the data shows that older adults aged 40 and older are more likely to use opioids than younger adults. And of course, that's, I'm sure, because of age and pain and surgeries and diseases, those kinds of things that account for the need for pain relief. And so more of that age group are getting the prescriptions for them. Women are more likely to use prescription opioids than men, and then non-Hispanic whites more likely to use opioids than Hispanics. And there's really no difference between non-Hispanic whites and non-Hispanic blacks in terms of prescription opioid use as well. And then, you know, where do people get their opioids? Well, you can see the gray bar shows that most people get them from a friend or a relative for free. You know, I live in a retirement community, and I can tell you that, you know, I get questions a lot about, do you have any of this? Do you have any of that? I've run out, or I need something, or I'm having a pain. So, and people look in their medicine cabinet and find it and give it to them. Then the red is the next category, and it is, they get them as prescriptions from their physicians. One physician or more than one physician. The next one, well, the green, which is low, very low on the bar chart, is where folks have stolen them from a friend or a relative. And then the next purple is they bought them from a friend or a relative. And then the blue, they bought them from a drug dealer or other stranger. And so it's interesting to see that most prescription opioids are actually obtained from a friend or a relative for free, right? So let's look at Louisiana. I had to cut this, out of a bigger map, but these are prescription rates for 2017, and the dark red parishes indicate that in these parishes there were over 112.5 prescriptions written per 100 people in these parishes, and that means more than one per person. So we got Richland, and I don't know how to pronounce all these, Rapides, Boyeles, Evangeline, St. Landry, Tang and somebody, Washington parishes have the highest rates in Louisiana of prescription rates. So I don't know if anybody who lives in any of those parishes, but interesting data to look at. And in Louisiana, providers, which are doctors who write prescriptions, they wrote, almost 80 opioid prescriptions for every 100 person, compared to the U.S. rate, which is 51.4 prescriptions for every 100 persons in the United States. Interesting Louisiana data. Also, 40% of the 1,140 reported drug overdoses in Louisiana involved opioids. And so, like I said, we get reports on drug overdoses, and it doesn't necessarily mean it's all opioids, but 40%. So in 2018, 444 fatalities in Louisiana. And then there might have been other overdoses involving opioids, but they weren't reported the same way and reported correctly. So not sure about that. And then this is the rate of overdose death in Louisiana. Beginning in 1999, I guess when they started taking the data, and up to 2018. And there was one peak in 2007, as you can see, and then it lowered a little bit, and then it started raising again 2013, and in 2018, 1,140 and 444 of those were related to opioids specifically. So, it rose, and then there was a dip for some reason, and then it's back up. It's rising up again. And I wanted to take a look at, okay, how does Louisiana compare to the surrounding states? And so here's, and this is a number of deaths per 100,000 total population. So we looked at Louisiana, Texas, Arkansas, and Mississippi, and you can see, let's just start with Texas, since I live in Texas, has one of the lower rates at 10.4, and then Mississippi, 10.8, Arkansas, 15.7, but Louisiana, 25.4. And I'm showing you the data. I don't know what exactly accounts for that, but and in all the maps that show states and the data for states, it looks like Louisiana has higher rates than many of the other states, usually falls into the higher category as well. And, you know, this just shows you that a comparison between other incidences of deaths, firearm deaths, homicides, and drug overdose deaths, the U.S. rates, and then this is the Louisiana rate, and that is 21.7 drug overdose, and so it's much higher than firearm deaths and homicides as well. Now, how do overdoses occur? There's a variety of effects that can occur when a person takes opioids, you know, from pleasure and relief of pain to nausea and vomiting. There can be allergic reactions, and sometimes it slows the breathing and the heartbeat, and sometimes those things even stop depending on the amount. So opioid overdose can be due to too many factors. So it could be that a patient actually, deliberately misuses a prescription, or uses an illicit opioid like heroin, or uses an opioid that's contaminated with another even more potent opioid like fentanyl. Overdoses can occur when a patient takes an opioid as directed by the physician or the prescriber, and the prescriber may have miscalculated the dose, or an error was made by the dispensing pharmacist, or the patient misunderstood the directions. So it can occur when opioids are taken with other medications as well, like some benzodiazepine or psychotropic medication that is used for treatment of mental disorders, or it can be taken with illicit drugs or alcohol, and that has an adverse interaction with those. And so the particular risk are individuals who use opioids combined with benzodiazepine or other agents or alcohol, and that causes the respiratory depression, because that's what causes death, is the respiratory depression. So, you know, there's a number of conditions or situations where somebody may have an overdose deliberately, you know, using something legitimately but with the wrong dose, or illegitimately as well. So who's at risk of overdose? And basically it's anyone who uses opioids for long-term management of chronic pain, and individuals who may use heroin or misuse their pain relievers. It may be people who have been discharged from an emergency room after they have had an overdose, and so they're at risk of overdosing again. It may be those who need opioid pain relievers and they couple them with other substance, that maybe they have a substance use disorder already. They need the opioids for some pain or condition or surgery that they've had. And so they've, you know, on top of they have to be very, very careful if they already have a substance use disorder. It may be that they have completed opioid detoxification, or they've been abstinent and then they return to using, or it may be that somebody who's been incarcerated for a while, and they have a history of opioid use, and they've been you know, released from incarceration, then they go back to using. So it can be, you know, it can be a number of different situations, individuals who are particularly at risk of overdosing. And so how do we recognize the signs of an overdose? If you suspect that somebody has had an overdose, you know, you want to, they're unconscious, or you give the sternal rub, where you rub here in the sternum and they don't wake up. slow or shallow breathing, difficulty, choking sounds, gurgling, snoring noises, and you can't wake them up. Fingernails are turning blue, purples, a slow heartbeat, low blood pressure. So first thing you do is call 911. You don't, you don't slap them or hit them, but you do try the sternal rub to wake them up and get them to emergency room, hospital, if possible. The other thing that you want to do if you suspect somebody has an overdose is support their respiration, because like I said before, the most important thing is, if the overdose affects their breathing, it slows down their breathing, stops their heartbeat. So you'll want to begin CPR and then be sure, that they are ventilated, and you'll want to administer naloxone, possible. How do you do that? Well, what happens with naloxone? Naloxone binds with the opioid receptors in the brain, and so it stops the effect of the opioid in the brain and in the body. And so if it's not working, then that's not an opioid that they've overdosed on. They may have overdosed on something else. If it is working but doesn't completely bring somebody around, you can administer it more than one time. And you can administer it intranasally, intramuscular, subcutaneous, or intravenously. And this is what it'll work on. These are the overdose drugs that it will work on. Like I said, it won't work on cocaine, marijuana, any other type of a drug overdose, only opioid overdoses. So let me show you what naloxone really, what it is, what it's about.
People are dying every day from opioid overdose. Parents and children, friends and neighbors. But naloxone can help. Naloxone is a safe and effective rescue medication that reverses the effects of opioids and saves lives. To understand how naloxone can stop and reverse the effects of an opioid overdose, it's helpful to see how opioids work in the body. Opioids are agonists. This means they bind to and activate specific receptors in the body, including the brain, brainstem, and spinal cord. When these receptors are activated, people experience the effects produced by opioids, such as pain relief, euphoria, calmness, relaxation, and slowed breathing. Taking too many opioids causes so many receptors to fill and activate that breathing may become dangerously slow and even stop. This is how an opioid overdose happens, and this is where naloxone can help. Naloxone has a strong affinity to opioid receptors, more so than most prescription opioids and heroin. But unlike opioids, naloxone is an antagonist. This means it attaches to opioid receptors without activating them. So when naloxone is administered during an overdose, it knocks the opioids responsible out of the way and allows breathing to normalize. Naloxone can be administered through an injection or a nasal spray. It usually starts working within a few minutes and lasts from 30 to 90 minutes. While one dose of naloxone can reverse an overdose, sometimes multiple doses are needed, especially in cases involving extremely potent opioids like fentanyl, or opioids that stay in the body longer than naloxone. Naloxone is very safe in single or multiple doses. It may produce withdrawal symptoms in people with opioid dependence, but it has no abuse potential and cannot cause an overdose. It's important to remember that naloxone is opioid specific. It has no effect on an overdose caused solely by non-opioid substances like benzodiazepines or alcohol. At the same time, people shouldn't be afraid to use naloxone when the cause of an overdose is unknown. If opioids were not involved in an overdose, it won't cause any harm. If opioids were involved, naloxone can save a life.
Okay. So that's about naloxone, how important it is. And it actually is available to anybody, to the man on the street. It used to, you know, if you're a family member of somebody who's ever overdosed or uses, you know, you can get naloxone. Also, the Good Samaritan law kicks in. If you are with somebody who's overdosed and you call 911 to get help for them, then you know, you won't be arrested or anything like that. So don't be afraid to do that. How do we prevent overdose? You know, we want to encourage providers, physicians, prescription pharmacists, people at high risk, people recovering, family members, to learn how to prevent opioid overdoses, how to recognize them, how to use naloxone, and then access to treatment for people who are misusing opioids or who have a substance use disorder. Access to naloxone, calling 911. You call 911 and you say, you know, and you give the address, so responders can come, and then encourage prescribers to use state prescription monitoring, drug monitoring programs. This is a database. When somebody is prescribed an opioid, they go in the database, and prescribers or pharmacists can access the database and see, you know, if they've been doctor shopping or pharmacy shopping and hopping and getting multiple prescriptions filled of opioids. So that, and many of them are in live time. So, you know, you'll know very quickly if somebody has been filling multiple prescriptions. You know, you might want to check if you're on the border. You might want to check with, you know, across the border, providers across the border, to see if you can also access their prescription drug monitoring programs as well. Righty. So we talked, you know, about the overdose, but we also talked a little bit about, when I was talking about injecting drugs, the risk of contracting HIV or hepatitis C problems as well. So you can see that there's, you know, many cases of hepatitis C problems in the United States, but I wanted also to look down and show you the state incidents. 7 new cases of acute HCV reported in Louisiana, and 50,000 persons living with hepatitis C in Louisiana as well. So based on the national average. So this is data from the drugabuse.gov state summaries. And the other issue is pregnant women and, you know, who deliver babies, and women are using opioids during pregnancy, and therefore the baby is born with neonatal abstinence syndrome or opioid withdrawals syndrome as well. So that's an issue for us to look at. And this is some data in 2016 and 2017. So in Louisiana, it shows that there were 5.6 cases per 1,000 hospital births for the state of Louisiana in 2017. It's a really sad issue and a sad problem, and I want to show you how it affects the babies and people, the pregnant women.
JC was 6 months old when her mother, Jennifer Frazier, who was struggling with an addiction to painkillers, accidentally gave her a fatal dose of methadone. We met Frazier at a Florida prison where she's serving up to 15 years for her daughter's death.
You put me away for a really long time. And I'm already suffering from the loss of my kid every day. So no matter what kind of punishment you give me, I'm punishing myself. And people make mistakes.
Reporter Duff Wilson led a Reuters investigation into cases like JC's and found many other examples.
We identified 110 cases since 2010 in which children died after being sent home with mothers who had used opioid drugs during their pregnancies. Now, there's a federal law that's supposed to help and protect those children. It says that hospitals are supposed to notify Child Protective Services about the newborns, not to remove them, but to provide services and to check out that their home is safe. But we found that system is broken. A number of times the hospitals did not notify social services even when the baby was going through drug withdrawal. And in other cases they did, but social services didn't do as much as the law says they should to help, and the child died.
As an opioid and heroin epidemic sweeps across the U.S., an alarming number of babies are born dependent on the drugs their mothers were taking. This video was taken in a hospital in West Virginia. The child's experiencing the painful symptoms of withdrawal, which can include severe tremors, violent spasms, and hypersensitivity. After 2 months of withdrawal, the boy in this video recovered enough to be sent home with his mother. In 2013, there were 27,000 drug-dependent newborns, 5 times more than a decade ago. The Keeping Children and Families Safe Act, passed in 2003, is designed to protect these infants, alerting authorities when a baby is born drug-dependent. But the Reuters investigation discovered that social services never hear about thousands of these newborns. We asked former Congressman Jim Greenwood, who championed that bill, about our findings.
It says that people are not following the law. It says that the states are not abiding by the law. It says that the hospitals are not abiding by the law. The doctors are not abiding by the law. And in many instances, the social service agencies that are there to protect children are not doing their job either.
Frazier says she wishes social service workers had intervened in her case.
Whatever happens, I just hope that from sitting here today, whether everybody in America judges me harshly or not, that maybe some kind of program will be made to where another little JC will be saved.
It's sad. Kind of personal to me. I have 2 nieces. One niece has adopted 2 little boys whose mother was drug dependent. Same mother, 2 years apart. Adopted one, got a call from CPS and said, you know, are you interested in a second one, because he has a little half brother. So they adopted that one, and 2 years later, the same mother had a third one, and my other niece adopted that one. And so, you know, even though the mother was put into treatment and given treatment and put in the hospital prior to the baby's being born to get her off of the detoxed off the drugs, you know, it keeps happening. So, yeah, I don't know. I don't know what the answer to that is, except for we need to be sure that, you know, if possible, that we can monitor and get help to these women as quickly and often as possible as they need it. And so, how did this happen? Current events. This is really interesting to me because it just grew, it just mushroomed into the problem that it is today. Here's a 1-paragraph letter in 1980 that started this whole crisis. This letter was written by a doctor who had done some just research in the hospital that he was in. He was in Boston University Medical Center, and he had a database of hospital records that he used to monitor the side effects of drugs in 1980. And he was interested in looking at addiction, so he asked a graduate student to calculate how many of his patients in the database got addicted after being treated with pain medication. And so he sent this letter to the New England Journal of America. Now, it's not a journal article, it's not research, it's a letter to the editor, 5 sentences. It said, you know, we examined our current files to determine the incidence of narcotic addiction in almost 40,000 patients who were monitored, and almost 12,000 who had received one narcotic or one opioid preparation. Only 4 cases of addiction had happened in those patients who had no history of addiction. So basically, out of 12,000 patients, only 4 patients developed an addiction. The addiction was considered major in only 1 instance. And the drugs implicated were meperidine, which is a semi-synthetic, and then Percodan and hydromorphone. So the conclusion was that despite widespread use of narcotics, drugs in hospital, the development of addiction is rare in medical patients who don't have a history of addiction, okay? So what happened here is that this 5 sentences began to accrue citations, and it just mutated. You know, other, like the Scientific American picked it up. Purdue Pharmaceuticals picked it up and started telling doctors that they were, their patients were suffering needlessly, and that they could use their own oxycodone to alleviate the pain that these patients were in. And it was non-addictive because of this extensive medical research that had been done by this doctor that was in the New England Journal of Medicine. And, you know, it was not an extensive research article. It was 5 sentences in the letter to the editor, and they called it an extensive. A researcher in 1990 in the Scientific American called it an extensive study, and then a paper for the Institute of Clinical Systems called it a landmark report, and then Time Magazine in a 2001 story called Less Pain, More Gain called it a landmark study, and that the exaggerated fear that patients would become addicted to opiates was basically unwarranted. And so that's how this started. Of course, the it was Dr. Porter and Dr. Jick were horrified that their letter had been misconstrued and used that way. Now, on the New England Journal of Medicine website, the Porter and Jick letter has an editorial note that reads, for reasons of public health, readers should be aware that this letter has been heavily and uncritically cited as evidence that addiction is rare with opioid therapy. The note then links a new study, you know, that basically says it's definitely not true. And so here's what Time Magazine said in 2001, that, you know, many physicians now concede that patients have been under-medicated for decades, suffer needlessly. One reason was concern that big doses of opiates could depress respiration, but a large part stemmed from exaggerated fear that patients would become addicted. This fear, which continues to hold sway over American medicine, is basically unwarranted. The landmark study, published in 1982, followed 12,000 Boston hospital patients who'd been given narcotic painkillers. After eliminating those with history of addiction, only 4 became addicted to the drugs. And so you can see that, you know, if you think back to some of the data that I showed you, 2001 is when the problems with opioids began to tick up and show more problems. And so this is how it started. Purdue Pharma developed OxyContin and began sending their pharmaceutical representatives around to doctors, telling them, you know, this is not addictive, but it will relieve the pain that your patients have. Doctors started prescribing it over and over, and that's how it started, and people became addicted. So definitely problematic. Let me see if I can get to this. Oops, I don't want to do that. Hang on just a second. I want to get to this website. And so do this. Okay. This is about a lawsuit that this city has now against the pharmaceutical company.
Every day it's getting faster. Everyone says go ahead and ask her. Love like yours will surely come my way.
Okay, you gotta have that.
Everett, Washington, a proud working-class town just north of Seattle. Now, like so many places, this city is being crushed under the weight of an opioid epidemic. Homeless addicts in doorways, overdoses in bars. Fed up and desperate for more resources, Mayor Ray Stephenson and his city have launched an unprecedented fight against Purdue Pharma, the company that has made billions off the opiate OxyContin.
Purdue needs to be held accountable for not taking the action they should have taken that allowed their drugs to hit the streets and make addicts of many of my citizens.
One mayor taking on a big drug company, deciding to sue after reading a Los Angeles Times investigation. The lawsuit alleges Purdue supplied OxyContin to obviously suspicious physicians and pharmacies, accusing the company of turning a blind eye to illegal drug trafficking. In a 2009 email cited in the lawsuit, a Purdue employee raises flags about a clinic in LA, now shut down. The line was out the door with people who looked like gang members. I feel very certain that this is an organized drug ring. The lawsuit claims the pills were then illegally trafficked up to Washington state. And the company never notified the DEA, which it is required to do by law. Is it your sense that this was a problem that could have been avoided, at least partially?
It absolutely is.
The oxy was everywhere, yeah. Everybody is a dealer, everybody has it.
Recovering heroin addict Lindsay Richards is describing Everett 15 years ago when she got hooked on OxyContin.
Children don't have their mothers because of this, and there's people that are dying every day because of what they've done.
In a statement to NBC News, Purdue says it's a leader in abuse deterrent medications, adding, "We are deeply troubled by the abuse and misuse of our medication. Our products account for less than 2% of all opioid prescriptions." This lawsuit paints a flawed and inaccurate portrayal of events that led to the crisis in Everett. The federal government has not criminally charged the company for failure to report possible illegal sales. Legal experts say if Everett wins the case, it will just be the beginning.
This could lead to an avalanche of cases from every city, every state in the country that needs money.
Are you getting calls from other mayors?
Yes.
A lot of them?
Fair amount.
Everett wants Purdue to pay tens of millions of dollars to help expand an often overflowing medical wing at the county jail for addicts going through withdrawal, or the kinds of services Richards needs to ensure she doesn't end up homeless again. How scared are you that you could end up back here?
Very scared because it's happened so many times.
Taking care of the addicts and the streets seems never ending. This dump truck is here 3 times a week. Now, Everett says it's time for a drug company to come pay for the cleanup. Stephanie Gosk, NBC News, Everett, Washington.
Okay.
Most of the time we look at it in the context of lethal force. But in this case,
let me close that out and go back to this. So many cities and some states now are suing the pharmaceutical companies that they have settled for billions of dollars. They don't take any guilt for it. They don't, say that they're actually responsible for any of this, but they are settling some of these lawsuits. Basically, these small towns who have these huge problems with opioid overdoses and are having to pay for it need to be reimbursed for the services that they're providing for folks who are in crisis with opioids. So there are a number of trends that also contribute to the crisis and play a role in the high rates. The first is the widespread prescribing of prescription opioids to patients. And since 1999, it has actually quadrupled the number of prescription opioids that have sold in the United States. In addition to the increase in number of prescriptions written, patients also receive opioid for extended durations and in higher doses. So overprescribing increases the volume of the prescription opioids diverted for non-medical use. If you've had a surgery, I had surgery recently and I was prescribed oxycodone, and I probably was given 30 of them and probably used 5 maybe, and so have these left over. And so, that's a problem with having them in your medicine cabinet and people asking for them, or children getting a hold of them, or people stealing them from you. So that's a problem, and that's why we have had prescription drug take-back days. The Drug Enforcement Administration has done that. Of course, we haven't in the last year because of the COVID, but that doesn't necessarily, it hasn't been shown to, hang on, we got a hand raised. It hasn't been shown to reduce the number of prescriptions or overdoses, but it is a way to, get rid of those things out of your medicine cabinet. So Veronica, I'm seeing that you raised your hand, and I'm trying to see where, have you written anything in the chat box, or is there any way I can see what you've written? Let me see more chat. So would you write in the chat box, the question that you may have? I don't have anybody yet written in the chat box. So I tell you what, when I finish here, which will be shortly, we'll try to go to some questions. My technician will help us with that. So anyway, we've looked at that. Prescribers and individuals taking opioids are kind of unaware of the characteristics of an opioid use disorder, such as developing tolerance to the opioids and then needing more and more over time. There is increased availability, purity, and relatively low price compared to some other prescription opioids as well. Heroin is cheaper than prescription opioids very often. And there are also some macroeconomic conditions in opioids misuse. They found patterns between unemployment rates and opioid related deaths in emergency rooms. Sometimes they call this as deaths of despair. And it suggests that industrial activity in a region, or the decline of industrial activity and job opportunities, are related to homelessness and depression and the use of opioids and overdoses with that. And so, these factors put people at risk for self-medication through the painkillers and prescription use of opioids as well. Let me do this, and I want to go down here and talk about here. I do want to do, a little bit of perspective because as a prevention specialist and former counselor, actually the biggest problem is underage drinking and alcohol and deaths by alcohol. And so I just throw this in, I'm just saying that mortality rates of alcohol versus heroin is difficult, but we're looking at alcohol-related deaths in this country of 88,000 compared to about 10,000 annual heroin overdoses. And this is just some data from 2014, an older slide, looking at drug overdose totals, and of those, so we're looking at like 28,000, 29,000 out of that number are opioid related. And so drinking too much can cause much harm to your health. We're looking at 88,000 deaths a year in the United States for alcohol versus, what would we say, 10,000, 20,000 opioids. And so I'm just throwing that out there because, we still need to look at, even though there's huge focus on opioids right now, we still need to understand and look at the issues that we have with alcohol as well. So your resource in Louisiana is this. This is your Department of Health in Louisiana. Opioids, the problem, challenge in Louisiana has data. You can go to CDC and Google, data on opioids and find state-related data, which is what I did and presented to you for the state of Louisiana. But this is a really good resource for you, and it has finding treatment, surveillance tools, things for patients, things for providers, and other resources. So I recommend that you go here if you have more questions and want more information about that. And this is me, and this is how to get a hold of me. And I'm going to